It's time, folks, so let's find our way in, please. My name is Steve Shoptaw. I'm from UCLA, the used to be free country of USA. And I'm here today to lead the session, this breakout session on methamphetamine treatments. Before we get started, I'd like to show my respects and acknowledge the Gadigal people who are the traditional custodians of the land on which this event takes place, and to the elders past and present. I want to just give you the structure. The people will come up, they'll make a presentation, they have 2 minutes for questions, and then my job is timekeeper today. I'll be monitoring the questions. Please use Slido, but I prefer to hear actual verbal interactions, so please raise a hand and a mic will find its way to you, and you can ask your question. So we're very privileged today to have Professor Nadine Ezard as our first speaker. She's an addiction medicine specialist and the professor and inaugural director of the National Center for Clinical Research on Emerging Drugs at UNSW. She'll be talking to us today about Lisdexamfetamine and the treatment of methamphetamine dependence. Professor Ezard.
Thank you for the introduction, and thank you for coming all the way from the US, Professor Shoptaw, to be with us here today. All right, so this is a trial called the Liam trial, Lisdexamfetamine. I'll just declare that I'm employed by St Vincent's and UNSW with competitive government funding but no commercial conflicts to declare, and acknowledge that these are all the authors on the paper, and there are a lot of people involved in this trial, including the participants. Just quickly, by way of background, there's about 36 million people who use amphetamine-type substances, and there's no medication treatment for this disorder. We are going down the agonist therapy approach with the principle that you can give a drug with a similar action to methamphetamine at a safer dose, safer route of administration, and fewer adverse effects. And this is the kind of framework that we use for other substance use disorders like nicotine use disorder or opioid use disorder. It theoretically both attenuates the negative reinforcing effects, so it treats the withdrawal symptoms, and also provides some degree of tolerance, so it also attenuates the positive reinforcing effects, so you don't get as high when you're using. And it also provides some kind of framework for regular healthcare and psychosocial interventions. The drug that we chose to use is Lisdexamfetamine. It's a prodrug of dexamphetamine, so it's metabolized into dexamphetamine in the red cells. That's a rate-limiting step, so that it means if you crush it up and inject it, you still have to wait for your body to turn it into dexamphetamine, so it doesn't have a faster onset of action. Because of that property, when they've done studies with people with injecting it, it has less so-called abuse-related liking intravenously than if you gave dexamphetamine. It's once daily oral, slower onset, lower peak concentration and longer duration of action than the immediate release dexamphetamine, which is what is available in Australia and used for the treatment of attention deficit hyperactivity disorder. Lisdex is used in Australia for binge eating disorder and for attention deficit hyperactivity disorder, but to a maximum dose of 70 milligrams. That is insufficient for people who are already tolerant to high-dose daily stimulants, so we piloted it up to 250 milligrams in a methamphetamine-dependent population in 16 people and saw no real adverse safety effects. So then we progressed to the randomised control trial, where we wanted to test the efficacy and safety of 12 weeks of 250 milligrams a day in reducing use. So we used reduction in self-reported days of use over the past 28 days as the primary outcome measure. It's a randomised, double-blind, placebo-controlled trial done in 6 different sites across Australia, and people needed to be methamphetamine dependent and reporting at least 14 days out of the previous 28, which is quite a high threshold. It's the group of people for whom psychosocial therapies work less well, and also ethically we felt to give a high-dose stimulant with all the known effects of a high-dose stimulant daily, people needed to be already more or less exposed to daily high-dose stimulant. We inducted people over a week, had 12 weeks of 250 milligrams daily, and then reduced over 2 weeks. People also offered a manualised 4-session CBT. And initially, this study was affected by COVID, and this is one of the big limitations with the study. So initially, we were asking for 2 times a week urine drug screen non-supervised, and we selected one at random for testing. Because of COVID, that was reduced. We reduced our visits to once weekly rather than twice weekly, and so then we just had it once a week, urine drug screen. And people had a long visit every 4 weeks and follow up 4 weeks afterwards. People were reimbursed for up to $290 each. So the primary measure, as I mentioned, was past 28 days self-reported methamphetamine use at the end of the 12-week intervention period. A secondary measure was the self-reported methamphetamine use over the full 84 days of the intervention, and then also a number of other secondary measures that you can see there in addition to the safety measures. 164 people were randomised, 155 received at least one dose, 100 were retained to week 13. So you can see that's not a great retention if you look at the ones that actually were taking the medication. That's only 89. So that's another one of the limitations of the study. People were perhaps a little bit older than we'd like. If we do actually get a medical intervention, we'd like to intervene a little bit earlier than an average age of 40, but that is what we expected. We had 60% men, and people were using around a mean of 24 days out of the past 28 at baseline. This is the gold slide. This is the actual data that we saw between the two groups. You can see, so the placebo group is the green one at the top there, and the lisdexamfetamine group is the red at the bottom. So in terms of our primary outcome, so that's at the week 13, there was only very weak evidence of a lisdexamfetamine benefit. So while both groups reduced, the Lisdex group reduced by about 2 days. But if you look at the secondary outcome, which was use across the whole 84 days, there was about a 9-day difference between the two groups. So we believe that it's potentially promising. It also brings up into question is what is a clinically meaningful decrease in use, which is where we also need to be progressing the field a little. In terms of serious adverse events, there were really, apart from nausea, there wasn't anything really concerning. Retention, as you can see, I already mentioned that the retention was not as we would like it, and I think future designs, we know that in other studies people actually reimbursed a lot more than what we did for participation in studies, and that might improve retention, we don't know. Other outcomes, and I think this is really important, even though this was a secondary outcome, but there was really far greater self-reported treatment effectiveness in the lisdexamfetamine group and greater treatment satisfaction. The blind wasn't perfect. People in the Lisdex group were more likely to identify correctly that they're on lisdexamfetamine, but I don't think that accounts for the whole difference that we're seeing there. The other thing that's important is that people didn't really come for counselling. This was a group of people that were looking for a medication treatment for their methamphetamine use disorder. So we only had about median of one session in both groups, and there was no difference between the groups. I already mentioned the COVID interruption. We did do some sensitivity analyses and didn't detect anything really significant between the pre and post-COVID groups. We did do a post-hoc power analysis, and it was only 65% to detect our primary outcome. Again, I mentioned retention was quite poor, but there was no difference between the two groups. Not everyone believes that self-reported days of use is a reliable primary outcome measure. We do, and we will continue to. There's no evidence that the people have a reason to not report what they think is going on. So, in conclusion, what are the practice implications? I mean, I think that the practice implications are very much in line with the recent American Society of Addiction Medicine and the American Association of Addiction Psychologists' findings that as a second-line therapy under close monitoring with trained providers, you could consider stimulant prescriptions for people with stimulant use disorder. We know there's known side effects of those medications, particularly psychosis and hypertension, which are also known effects of methamphetamine. So you do need to monitor people closely, make sure the risks don't outweigh the benefits, and to make sure that people are starting to see some outcomes. And I think For me, I do prescribe dexamphetamine off-label. We've been doing that for quite a long time. What this does add for me just immediately in terms of clinical practice, if you're going to see a difference, you will see a difference within the first 4 to 8 weeks. So that helps you decide for whom this might be useful on a continuous basis or not, and also helps with the kind of discussions you have with people when you start prescribing off-label, because it's still not approved for use, around how long we'll give this a go to see if it's helping you meet your treatment goals. I think one of the things, around 40% of the treatment group screened positive for childhood ADHD symptoms using the Wendy-Utah rating scale, and that's higher than what you would expect in the general population, and probably reflective of what we see in most substance use disorder treatment populations. So in future studies, we weren't powered to detect a difference, but I think we really should in future studies look at stratifying by ADHD status, and it also brings up that whole question that I've been talking about with some people today about treatment of coexisting ADHD in our populations. And I've mentioned clinically meaningful outcomes. Thank you. Oh, that's the publication if you want to look at it.
Yes, already there's one. Outside of a research context, do you foresee reimbursement to be a part of the treatment model?
Reimbursement for coming to treatment?
Or the Lisdex, I think.
Is that, so...
If you're outside of the research...
So I'll answer the two ways I interpret the question. One is if the medication is paid for. I mean, if there's sufficient evidence for this to be subsidised by the government for treatment, then that would be... obviously ideal. In terms of actually, if you're talking about reimbursing for coming along for evidence-based treatment, we would call that probably contingency management. And we're not talking about contingency management here today, but that's a whole other area of investigation for the Australian context. We're aware that it's used in other contexts, but it certainly isn't in Australia yet.
Other questions? So I have one.
Yeah.
How comfortable were the participants with the medication? Did you get asked for dose reductions or in your running your trial?
No, there wasn't really scope for dose reduction in terms of the protocol, and people were given with the modified protocol after COVID, 1 supervised and 6 take-home doses where people could administer their own medication, and then we asked them what they took, whether they liked it. And so I guess people could, without reporting to us, reduce their dose themselves if they wanted to, but it certainly wasn't something that appeared in the data as people finding that dose too high. It only translates to, in terms of potency, less than what methamphetamine here is used in points, which is 100 milligrams, probably a bit less when you account for weight change and purity changes. So the dose we're giving is less than the equivalent of that 1 point, and people are usually using much more. So we didn't, particularly that group that's come into the trial, so no one said to us it's too strong.
Yeah. Other questions? David?
In your off-label experience regarding duration, this was a 12-week trial. What do you do long-term? Do you kind of just continue on as they're doing well, or do you have a...
So that's a really great question in terms of clinical practice. So the way it works in New South Wales, which is different to the other states, I'm not sure other states even have the capacity to do this, but we do have permission from the government to use off-label dexamphetamine for the treatment of stimulant use disorder, and the permit is provided to me on a 6-monthly basis. So I do close monitoring, and on the basis of this, if people aren't starting to meet their treatment goals, which usually are reducing use or ceasing use, then after the first 3 months or so, then we'd start to wind down. The people that do actually attain their goals of abstinence and find the dexamphetamine really useful, we do a really slow reduction, and people have been reducing over 2 years. So that there's no sort of end point really, it's just clinical. Yeah.
Thanks, Professor Ezard. Thank you. A round of applause. Thank you. Next up, we have Professor John Brett, and Jonathan Brett is a senior staff specialist in clinical pharmacology, toxicology, and addiction medicine at St. Vincent's Hospital and a clinical toxicologist with the New South Wales Poison Center. He'll be presenting today on PsiMA trial of psilocybin-assisted psychotherapy for methamphetamine use disorder. Professor Brett.
Thank you for inviting me to talk and just recognising that we meet you on Gadigal land and pay my respect to elders past and present. Okay, so it's now the sort of the plat du jour, isn't it? Psychedelics, and it's what everyone's quite excited about. So I think it is important to enter this area with equipoise because there's a lot of zealousness in this area as well. So I think it's important that we maintain good scientific rigor as well. So I'm just going to tell you a bit of background and a bit about the sort of small pilot study we did as a sort of preliminary look at feasibility and safety. So just to place, these drugs in context, so there are a range of different drugs that have been looked at in the last a reemergence in the last decade for therapeutic potential, but the one I'm going to be talking about today is psilocybin. The other thing to say here is that it's really important when I'm talking about this kind of work that the focus is on the psychotherapy and not the drug. So really, if we look at sort of mechanisms of action, these things are really just an accelerant to psychotherapy, not a treatment in itself. That being said, we know a bit about sort of how they act in the brain. So they mostly act in sort of serotonin receptors in the cortex. Psilocybin itself is found naturally in psilocybe mushrooms, lots of different species. We know a lot about its pharmacology as well. So when we're talking about psilocybin, what are we talking about? So the kind of therapeutic model we're talking about is there's a sort of difference between macrodosing and microdosing. So macrodosing, you're really aiming for people to have a full psychedelic experience. And special considerations given to the headspace or the mindset people are in going into the psychotherapy, going into the the experience with psilocybin, and the setting in which they have it, because it's all very sensitive to that those considerations. So historically, this treatment's been given by a therapy dyad, so two therapists, mainly. So historically for sort of psychodynamic reasons, but mainly for practical reasons, people come in for 6 hours during the day, and to ask one therapist to sit through 6 hours is quite a lot. So generally, the model is you have some preparation psychotherapy beforehand. You come in, have a dose of psilocybin, you stay all day, and then you have some integration therapy afterwards. The role of preparation therapy is really to sort of form alliance with your therapists, feel really safe and comfortable, do some treatment planning, and kind of set some goals. Integration is really trying to make sense, put narrative to your psychedelic experience in the context of the goals you formed. It's quite different to microdosing, which is really no therapy. You just have a much smaller dose of a psychedelic, second or third daily dosing, historically because of concerns around cardiac valve issues. So why has most research been done with psilocybin? If you look at sort of differences in therapeutic effect and duration of action, you can see there, DMT is like the shortest and really very abrupt onset of a psychedelic experience compared to something like ibogaine, which sort of more gradual onset but lasts much, much longer. So psilocybin sits somewhere in the middle there where, it's a kind of reasonable onset so people aren't being thrown directly into a psychedelic experience. But, it lasts about, peak effect is about 2 hours, and then the whole thing lasts about 6 hours, so somewhere in between. That being said, there are research projects ongoing with DMT and, all the other psychedelics as well. So it's just a word diagram of the research that's been done so far in terms of indications on psilocybin. So you can see there, the most has been done around treatment-resistant depression, major depressive disorder, end of life. But, there are emerging program of research looking at substance use disorders as well. So just to sort of briefly touch on the fact that depression, psilocybin-assisted psychotherapy for depression is, evidence is fairly strong now. There's been at least 2 large randomized controlled trials, phase 3 trials, a number of other trials, and meta-analyses to show that it does improve depression symptoms. What's been done for addiction in this space? Well, there's an older study of a meta-analysis of studies done on LSD psychotherapy for alcohol, which is sort of pretty convincing, but most of the studies are old now. And when you look at the 12-month follow-up, it's not as convincing. There's been a number of studies done on alcohol. This was the first one done by Bogenschultz, based in the US, which was a pilot study that showed a signal for heavy drinking days. And then the same group went on to do a randomized controlled trial that showed positive impacts across a range of indices for sort of alcohol drinking. This trial has been criticized for kind of recruiting maybe a less heavier drinking population. You only needed to have been drinking 4 or more heavy days a month. But you can see there sort of fairly good numbers needed to treat, 4 to 7 in comparison to like other pharmacotherapies like acamprosate or naltrexone, where it's more like in the sort of 15 range. And then more recently, another RCT published a smaller one, but looking at a residential rehab population. And again, sort of great number needs us to treat of like 3, 7, but fairly big confidence intervals there because it's a smaller population. Other things, an older study looking at opioid use disorder in a residential population, again, convincing results, but like preliminary, and some convincing results, but again, small sample size for smoking cessation. And there's ongoing randomized controlled trials in these areas as well. So what we do know is there's a good correlation between the dose of psilocybin you give, the psychedelic intensity, and the clinical outcome. So I'm not going to linger on this, but like there's good rationale why methamphetamine, why psilocybin psychotherapy is useful, might be useful in methamphetamine use disorder, but there's some particular considerations we need to take. So we did some naturalistic work looking at people who were regularly using methamphetamine and used psychedelics as well, and the population we surveyed had high rates of mental health, suicidality, psychotic symptoms. What we found was there was some really good outcomes in over half the population in terms of improved social function and substance use outcomes, but actually about a third had negative outcomes. So it's not a benign thing. Like people can have bad experiences. Okay, so what's unifying all this? Well, I think sort of this area of research is really interesting because it sort of leads to rethinking how we categorize mental health and illness. And so what's in common with all these conditions that might be helpful, that where this intervention might be helpful is, mental flexibility, social connection, mentalization, rumination. And so, the psychedelic experience phenomenology is kind of the opposite of that. So I won't go into this, it's kind of complicated, but basically computational psychology, so our ability to model consciousness using sort of computational models now, is this hierarchical predictive processing modeling. Essentially, what psychedelics sort of hypothesize to do is be able to shift your weighting of high-level priors, your deeply held beliefs about the world, in a contained environment to a more helpful, productive way of seeing the world. So what did we do for our study? Well, it was a pilot study, safety feasibility study. We took 15 people who were treatment seeking, a stimulant treatment program. Initially, we only recruited people who were using less than 16 days, but after 3 people, we realized that was not necessary and too restrictive. We wanted to sort of really make it as generalizable as possible, potentially. And like I say, we're looking at safety feasibility, but we looked at a number of secondary outcomes, methamphetamine use, cravings, quality of life. I think critically, and I'm really happy we did this, we built in a couple of sub-studies looking at qualitative outcomes, and we did fMRI scans before and after treatment as well. This is our beautiful treatment area. I think all treatment should be like this, not just people receiving psychedelics. So we gave 3 preparation psychotherapy sessions, 1 dosing day, and 2 integration psychotherapy sessions over about a month, and then we followed people up for 3 months. Again, no particular surprises here. Again, as always, more men than women, which is something we need to work on. Maybe slightly more educated and slightly lower. Average use was about 12 to 14 days a month. So really no serious adverse events, very minimal adverse events in general. And this is sort of graphs of heart rate and blood pressure during dosing, and no issues there as well, you can see. We thought there might be dose blunting because methamphetamine and serotonin receptors and downregulation of those, but actually most people had a really full psychedelic response with very minimal there was some challenging experiences, I'd say just enough, but really no signals there to be concerned about. What about methamphetamine use? So we tracked across baseline and all the therapy. There wasn't much change there. But actually after the dose, it dropped to 0, a median of 0 at day 28, and then a median of 2 at day 90. So again, don't overinterpret this because it's a single-arm study, but promising. On this side is cravings, similar story. And then there's quality of life measured by the Warwick Edinburgh Wellbeing Scale, and depression, anxiety, stress measured by DAS, and again, improvements. Qualitative experiences. Again, the thing that seemed to come up again and again was the experience during psychedelics was really rarely or never about methamphetamine. It was generally about some early life attachment trauma that they were presented with using some kind of very vivid imagery or like metaphor that they were then able to confront and find some resolution with. And we call that leaning into the obstacle. Hopefully that paper will be accepted very soon in addiction. This is my last slide. So we also did these functional MRI, and I'm really not going to go into details here, but generally what you see in addiction, in meth as well, is segregation of brain network activity. And when you look at it, so particularly the default mode, executive control and salience networks, and really decreased connection to the rest of the brain. And what happens with addiction treatment, we know, and what we saw with this treatment in particular was that decreased segregation and increased connectivity to the rest of the brain, and it was correlated statistically, even in a small group of people, with clinical outcomes. So lots of challenges with this area. I'm running out of time, so I'm not going to linger on that. And we hope to do a randomized controlled trial, still applying for funds for that. Thank you for listening. I think that's it. Big thanks to NCREDS as well for the funding. Yeah.
Great. Time for one quick question.
I'm around.
Okay,
afterwards.
awesome. Yeah. Thanks, Jonathan. Our next presenter is Dr. Krista Siefried. She's clinical research lead and deputy director at the National Center for Clinical Research on Emerging Drugs and senior lecturer at NDARC. Her presentation today is oral naltrexone bupropion combination pharmacotherapy for methamphetamine use disorder, a pilot trial in the Australian context. Professor.
So I would like to just acknowledge the study team, many of the people who are in the room, and really key to this particular presentation is that this is a pilot study, but it also, I'm going to overview some data of an RCT that it is largely based on, and of course that RCT was conducted in the US by Steve Shoptaw and Maduka Trivedi. So just acknowledging that Steve is here and very fittingly the chair of this session. I'd like to acknowledge the study coordinators at St. Vincent's. I think Lucy's here today, and the work that they put into this project as well. The NABU trial was sponsored by the National Centre for Clinical Research on Emerging Drugs, and NCRED receives funding from the Australian Department of Health, Disability and Ageing, and I'm employed by UNSW and St. Vincent's. I'd like to acknowledge country and lived experience before I launch into the data. So I acknowledge that the research that I'm presenting took place on Gadigal lands in the Eora Nations, and I'd like to recognize the strength and resilience of those people who maintain a continuing connection to those lands and waters, a right and responsibility that was never ceded. And I'd like to acknowledge the contributions of people with lived and living experience to this project through focus group participation, as a consumer investigator, as participants in the trial, and in qualitative interviews. They brought knowledge and wisdom along with a commitment to altruism throughout this research. So methamphetamine use disorder, or dependent methamphetamine use, is globally estimated to be about 96 people per 100,000 population, and Australia is really leading the way, in particular with methamphetamine as a stimulant of choice, and we see prevalence rates up to 7 times the global average. Currently, there's no pharmacotherapy that's been licensed or approved for methamphetamine use disorder. As we've already heard today, there are pharmacotherapies that are used off-label for this purpose. and recommended for off-label use in methamphetamine use disorder includes the combination of bupropion and naltrexone. I'm not sure if you, sorry, my slide looks like it's cut off, but you've got the references there, and that's the most recent ASAM guidelines out of the US. So that's US guidelines. We don't have stimulant treatment guidelines such as those in Australia yet. So naltrexone and bupropion. Naltrexone's an opioid antagonist. Most of you here will be well acquainted with this. It's established as an effective treatment in opiate use disorder and alcohol use disorder. Bupropion is an atypical non-tricyclic antidepressant. In the US, you can use this as antidepressant. In Australia, we use it for nicotine dependence. The US RCT, Steve Shoptaw, Meduco Trivedi, I think I got the reference there for you, was a randomized controlled trial where participants were randomized to either a depot naltrexone every 3 weeks plus 450 milligrams of extended release bupropion orally per day versus placebo. So these were randomized at either a stage 1 randomization or an adapted stage 2 randomization. So a very fancy and expensive trial with very fancy and expensive compounds. The primary outcome in that trial was response, which is greater than or equal to 3 out of 4 methamphetamine negative urines in the last 2 weeks of treatment. And naltrexone and bupropion had a greater treatment effect than placebo. So when we looked at this study, we got excited like the rest of the world. Look where it's published. However, those formulations are not universally available, which limits their translation to diverse contexts. They're expensive. I actually double-checked these numbers with the US group before I published our protocol paper, and indeed, depot naltrexone comes in at $1,000 to $1,700 US per dose. So possibly prohibitive even where those compounds are available. So we decided to undertake an open-label pilot trial of more readily accessible compounds in Australia, and this is the NABU trial. Our primary aim was simply to determine safety and feasibility of orally administered naltrexone-bupropion combination pharmacotherapy over 12 weeks in adults who were seeking treatment for methamphetamine use disorder. So hopefully that's not too small. It looks really small on this little screen I'm looking at, but hopefully you can see. We had an oral extended release combination, so we used a combination tablet used predominantly for weight loss or weight control, and it's in divided doses of an 8 milligram naltrexone, 90 milligram bupropion in divided doses daily. So our total max dose was 40 or 450 in 5 tablets. The primary endpoint was at day 84, which was the last day at the highest dose. We did have a brief induction period, 5 days, starting at 8 milligrams and 90 once daily. That scaled up. By day 5, you were on the full dose, and then day 84 being that primary endpoint. We did follow up to week 17. We enrolled 20 participants. They were adults seeking treatment for methamphetamine use disorder. They had to be opioid-free for more than 7 days by self-report, and this was verified with a urine drug screen, which was positive for methamphetamine but negative for opioids. They couldn't have physical or psychiatric conditions that would interfere with study participation, so this wasn't necessarily an exclusion criteria. It was really just if they were on a concomitant contraindicated medication or if there was something that was going to make them unlikely to attend visits, for example. So they couldn't have a coexisting dependence or anticipated withdrawal from alcohol, benzodiazepines, GHB, and no history of seizure disorder or history of seizures, known CNS tumors. And this all comes back really to drug effects of the bupropion naltrexone combination. And that includes the use of MAOIs in the previous 14 days. So our primary outcomes were feasibility, and we defined that by the time taken to recruit the sample, the proportion of ineligible participants, the retention in study, and the adherence by pill count and the SMAC questionnaire, and safety, which we identified through treatment-emergent AEs and adverse reactions. And then we also, similar to what Jonathan mentioned earlier, we ran a whole bunch of secondary outcomes, and we, of course, included our qualitative study. So the protocol was published in BMJ Open, so you can refer to that. Essentially, we had weekly study visits, fortnightly study medication dispenses, and returns for pill counts via Webster packs, so daily, because of the divided doses daily Webster packs. We had a daily ecological momentary assessment, so a smartphone application, which notified your mobile phone to complete a 24-hour adherence questionnaire, as well as methamphetamine use questions. I still have questions, and Liam will look at this data in more depth, but I still have questions of whether this was actually an adherence intervention or an adherence outcome measure. I think it's both. And then also everybody was able to access treatment as usual, including psychological care. And of course, there is our study flow chart there. And so on that flow chart populated with numbers, we had 183 expressions of interest to participate in the study, and we were able to screen 24 of those to enroll our target sample of 20. And on study at primary endpoint were 15 participants. So the reasons for withdrawal included incarceration, admission to a residential rehab that didn't facilitate follow-up, and then a couple of participants became non-contactable through the study. And I will talk about the adverse event that resulted in one withdrawal as well. So 20 participants enrolled, similar with the study figures from Lima that Nadine presented earlier. We had a median age of about 37 years, predominantly male, as is a perpetual issue with our pharmacotherapy trials, overrepresenting males, and that doesn't actually match treatment data, but that's a whole other talk for a whole other day. And just some more demographic data there that I might just skip through in the interest of time. So substance use at baseline was a median of 20 days of the past 28, and the average daily use was 3 points. Substance use recovery goals and expectations over the next 12 weeks. The majority of participants actually wanted to stop using methamphetamine altogether, while the rest wanted to either reduce their use, and one participant came on the study unsure exactly what they wanted to achieve. Most common comorbidities were depression and history of suicidal ideation. Concomitant medications in line with this population were mirtazapine, benzos, sildenafil, and PrEP. Time taken to recruit the sample was 20 weeks, which when you compare to other studies is fairly competitive. Including screen fails, that's about just over one participant per week. The proportion ineligible, we had a lot of pre-screening, a lot of active nursing intervention to get our participants pre-screened and keep our enrollment figures quite realistic. So 24 participants or 24 patients were formally screened for eligibility, and the vast majority of them were able to enroll. The screen failures were basically around drug use, so too little methamphetamine or too much being any opioids. That's my timer, but I still have time on this timer, so I'm going to go for one more second. So retention in study, 75% received all study medication up to the primary endpoint, and 65% completed that follow-up visit. Medication adherence was hard to make sense of. Lack of returns was a big issue within this subset, and pill counts were a big issue. I'm hoping that we're going to learn a little bit more about alternative ways to measure adherence from Rebecca's presentation, which I think follows mine. Treatment emergent adverse events, there were 93 amongst 19 participants. One was classified as serious. That was a hospitalization for methamphetamine withdrawal, so it was unrelated to study medication. However, one AE did result in a participant withdrawing from the study medication. That participant reported that the study medication resulted in lethargy, and that when the medication was ceased, the lethargy resolved as well. That's not an anticipated response to this medication combination, but that was the report from the participant. Otherwise, the most commonly reported AEs were around nausea and vivid dreams, both known to be anticipated side effects of this combination. Notably, because I did mention earlier, if you recall, that this is a licensed drug for weight loss or weight management, only one person had an adverse event of weight loss. So really quickly into a discussion, naltrexone and bupropion were safe in this population. The study procedures were feasible. Adherence was an issue. Unreliable data, so the level of adherence we can't really say with certainty, and the incomplete questionnaire data across study visits was also a problem, but Liam will look closer at that EMA data. Adherence was greater in the US RCT, but let's not forget that one of the medications in the combination was given by 3 weekly injections. The study was small, it's a pilot study, and while implementation data is useful, we can't really say anything about the efficacy of this combination. Randomized control trials are required, and really we need to take into account the qualitative data, which my colleague Harriet and Liam are looking at the moment as well. And I don't even know if I have time for questions, but I'll be here all day. Thank you. For the record, I still have 2 seconds.
Yeah, so I'll ask the question.
Okay.
So 450 milligrams of bupropion is a big boost. How did your participants respond to that dose?
Well, we didn't get we had a few participants who found it quite zingy, but then the one that withdrew had quite the opposite effect with the lethargy. So
Maybe that was because they stopped using methamphetamine.
It might have been.
Who
So,
knows?
yeah.
Okay, great. Thanks,
Thank
Krista.
you.
Okay, moving to the next presentation is Professor Rebecca McKetin. Professor McKetin leads a research program into stimulant use epidemiology and interventions at NDARC, UNSW, Sydney. You'll be, that's you, yes. You'll be presenting today on the TINA trial.
Thank you very much, Steve. So today I will be presenting on the TINA trial, which is a trial of mirtazapine for methamphetamine use. The rationale for this study is that mirtazapine, well, for those of you who aren't familiar with it, it's a generic tetracyclic antidepressant drug. So being off patent, it's quite cheap. It's got a really well-established safety profile. And there have been 2 phase 2 trials in the USA which found benefits in terms of reducing methamphetamine use. The first one was done and published in 2011 by Grant Colfax and his colleagues, and I'd like to acknowledge some of those colleagues are here today with us. Thank you, Steve. And they found that 12 weeks of 30 milligrams of mirtazapine a day reduced methamphetamine use relative to placebo. In 2019, that was replicated by Phil Coffin, which was published in 2020. He went up to 24 weeks, same dose, and the benefits became apparent at 12 weeks, and by 24 weeks, there's still benefit there, but it wasn't any greater. Both of these studies were conducted amongst men who had sex with men and transgender women in a very controlled environment. So there's no women in these studies, importantly, in case we matter. And then also they excluded anyone with major depression. And if you work with people who use methamphetamine, particularly when they're going to treatment, there's high prevalence of depression. So we took this to mean, well, this is very positive, it's very good evidence, but we needed something that was a bit broader, and that's what we call a phase 3 trial, where we look at the efficacy and safety of this drug in a broader population of people who use methamphetamine and in a more real-life setting, so in routine clinical practice. We were very fortunate. I mean, we did manage to get funding through the NH and MRC scheme, but very thankfully, this other scheme came up through the MRFF at the same time, and it gave us a lot more money, basically, so we were able to run a really good trial. And the purpose of the funding is to repurpose medications. It takes a very long time to get a new medication off the ground, and if you can take an existing medication and repurpose it, it's much cheaper and much faster. So the intervention that we trialled was the same as what had been trialled previously in the USA. It's 30 milligrams of mirtazapine. It's a standard starting dose for depression, although we didn't taper up, which you would do with depression. We just went in with 30 milligrams because that's what had been done in the USA. We compared that to a matched placebo. You can actually see our tablets here on the right, provided by APO. And we gave that to people as take-home medication for 12 weeks. You can see there our bottles have very, very expensive kit on the top of them, which monitors how often people open the bottle and take the medication, and that's how we monitor medication adherence. You can also see very conveniently they have a number, and so you take 1 tablet a day. And if you're like me, you can never remember if you've taken your medication. We didn't want people overdosing, so that was quite convenient to have that little display there. And then we replaced that every month for 12 weeks, and we followed people up until 20 weeks afterwards. So that was our intervention. We worked through 6 different alcohol and other drug services around Australia, and Brisbane, Wollongong, Perth, Adelaide, Geelong and Townsville. And you can see here Michael Christmas in Perth, along with Lily Palmer, who's in the audience somewhere. Yay, go Lily. And lots of other very enthusiastic research officers who did a wonderful job. So the doctors at the service provided the medical support, but we had a kind of a unique model of care in that we have our research officers who would go out into the field and do interviews. And so that's probably one of the more unique aspects of our trial. We didn't wait for people to come to us, we went to them, and we paid them well. And that, we got, as you'll see in a minute, very good follow-up. We also were able to recruit, and one of the things that we did in this particular study, and I will say every time I run a study, I think I know how to recruit people, and it's always different. But what we had to move to in this study was a lot of social marketing, and quite aggressive social marketing. We paid a company to help us target people who use methamphetamine, which is not easy because the Facebook algorithm doesn't have a tab for methamphetamine use. So that required some creativity. And we got a graphic designer to help us come up with logos which were co-designed with people who use methamphetamine. So very targeted. We also put a lot of these stickers on fit packs and did a lot of word of mouth. So we recruited a lot of people. If people were interested, they could also register through our website. We had a dedicated website, and they could register anonymously online. That was stored on the UNSW server, so only we had access to that information. It was confidential, it was secure. And then what we would do is Lily and the other research officers working on the project would actually phone the person up and tell them about the study. So we got a lot of inquiries that way. Not the best hit rate, because it's hard to get back in contact with people. But we managed to screen over 1,000 people, and I think that speaks to how many people are out there who are interested in accessing some kind of care for particularly pharmacotherapy for meth use. And about half of those hadn't been to treatment for their methamphetamine use before. So we're really reaching out into that population and that unmet need. Of those, we randomised 344. We had a few that we couldn't recontact, didn't turn up for their baseline assessment and get their medication in the placebo group, but basically we got 339 given them the treatment. Whether they took it or not is another matter. And based on the return bottles, we got about 62% adherence for those who hadn't discontinued. And I'm not going to present that data because it's under embargo, but we did have a lot of discontinuations. With those procedures, we're able to get, on average, 66% follow-up week 12, and no, sorry, not 66, 86, quite a big difference at week 12, and 89% overall. So we're very happy with that. Similar to the previous studies, we had an older group of people, so I think we're dealing with an older age cohort here, particularly for injecting methamphetamine. In our case, we actually had about half of them smoking, so 46% injected and the rest were pretty much smoking. 37% women, so we were able to get into the women who were using methamphetamine as well, which is nice. And the criteria was moderate to severe methamphetamine use disorder, and they must have used at least twice weekly in the past month to get into the study, and we did do a screen for amphetamines. And our average use was 24 out of 28 days. So you're looking at near daily use, if not daily use. And I think that's very similar to Nadine and Krista's studies and other people's studies, a little bit different than the PsiMA study. We also did the PHQN, and about half of the sample were depressed, and that cutoff that we use concords with a diagnosis of major depression. So it's good that we were able to capture that population. The good news, well, maybe not so good news, is that beautiful graph here, you can't see, it's under embargo. So I'm going to move the time frame for the presentations in the session along a little bit here. Yes, and the conclusion is under embargo. I would like to acknowledge the many people who contributed to this study. We've also got Noni and Lucy sitting up there in the audience, and I'm not sure if there are any other investigators here today. This was a well-resourced study, and we had full-time research assistants embedded at each of our clinical trial sites, which is a real luxury and absolutely necessary for the study. And not only did we have many investigators, including Steve and David, various other people, we also had a lot of people on the ground around the country helping. So it was an enormous effort. I'd like to thank them all. And this was me when I started the study. You might not recognize me now. So I put that up there, Faces of Meth. And if you're interested in the results, please keep an eye on our website, tinatrial.info, and that's where we'll be posting the results as well as putting them out in other places. Thank you.
Quick question, someone? So I had a question. So in terms of medication adherence, are you thinking of doing a covered analysis? So you'll look at the amount of effect you get for people who actually have matching pill counts with the pills that they've actually taken the medication? Or what are you thinking about looking at in secondary analysis to see if there's some sort of effects there?
Yeah, so we are looking at doing a per protocol analysis, but our statistician, Phil Clare, has informed me that I must not do that without appropriate weighting to control for the biases that will introduce.
Yeah, that's a good point.
Because obviously people who stop taking the medication do so for reasons other than, where they're allocated, so whether it's working or not. So he's going to write a whole paper on that.
Very nice, very nice. Jonathan.
Well done on your recruitment and retention. It's very impressive. What's your sort of secret sauce for recruiting women? Is it social media?
Can you repeat that? What's the special sauce for recruiting women?
The secret to recruiting women? I've never had a problem doing it in any of my studies, so I don't know how you don't do it. Actually, maybe because we're all women on this team. I don't know. It's never been a problem. I mean, we do know, I do have to say, the only thing I could think, you probably have more trouble in services. We're going outside of services and we're doing social media. So, I mean, it was a bit hard with the social media strategy. Like, you might look at things like trades and then you go, well, what would be a male-dominated field? So what would be the female-dominated equivalent? Yeah, Krista.
You also have to give credit to your outreach program, right? It's a lot easier to bring your kid to the library or a cafe. It's a lot easier to meet at a playground with the RA than it is to come into a setting where you might get busted by other moms walking into a drug and alcohol treatment center, or there's a lot there, and there's a lot about childcare and about the visual aspect of being found out for your methamphetamine use. So I think that's I think you have to remember to credit yourself for that outreach. That was good.
Yeah, I think the outreach improves confidentiality. Absolutely.
Hi, Rebecca. Could you talk to the bang for the buck of recruiting through social media? I remember a study I did actually with Steve. We tried this and we got a quote from Google. I got a call and they wanted $90,000 a month, which is really not in budget. And when we did with very little money, we got zero.
Yeah, we've had the same thing. Like when I've tried to do it without the big budget behind it, didn't work. And I don't know, I'm the wrong generation to ask. I couldn't do it, but we did manage to do it. And we actually had a few studies at NDARC who were using the same technology. And so that company was paid a lot more of a modest amount to set up the scheme. And then they trained us in how to manage the actual platform, and had a postdoc at the time who thought she was going to do research and ended up being a social media queen, managing that social media platform and continually refining the algorithm. So I won't quote you here in a public forum on exactly how much it is, but I will say that when we got another quote, it was not feasible. So it's a hard thing to set up, but once it's going, you can turn the volume up and down. It's very convenient. So I think we work together, perhaps, to do something like this.
Thanks much.
Thanks.
Okay, our next presenter is Dr. David Goodman-Meza. He's a senior research associate at the Kirby, UN Southwest, UN, I work at UT Southwestern, so I have this, UNSW, Sydney. Okay, all right, David, you're presenting on Semaglutide for methamphetamine use disorder, pilot randomized trial.
Sorry, left-hand side. Hi, well, thank you to NDARC and Rebecca for the invitation to present. I was told that I was presenting for 5 minutes, and I see 11 minutes, so I don't have enough slides to fill it up, but just give me the holler when I should stop. I would like to acknowledge that we're currently on unceded Gadigal lands, and I want to honor elders past and present. And then at the end, I'll have a slide to acknowledge all the different co-investigators at the different sites where we are hoping to conduct this trial. As you may or may have not picked up, the title that Steve mentioned, a randomized control trial, actually has changed because it's going to be a one-arm, open-label study. So there will not be a control arm. Next slide, please. Oh, do I press it? I didn't come to the training, sorry. Of course, this is speaking to the choir, right? But new, safe, and scalable pharmacotherapies are needed for the treatment of methamphetamine use disorders, and glucagon-like peptides, GLP-1 agonists, receptor agonists are the wonder drug, right? And if you follow any news feed on new advances in clinical research, you can always see every week on week a new study published in the New England Journal on how one of these new agents improves some kind of health outcome, be that obesity and diabetes, which it's somewhat designed for, but now fatty liver, cardiovascular outcomes. And then there's, of course, been data, small data published in JAMA Psychiatry around alcohol use disorder, and then data recently presented at CPDD around tobacco use. So can the wonder drug be used in this disease that we are still lacking pharmacotherapy for? So our aim is of course, to evaluate the feasibility, safety, and preliminary efficacy of Semaglutide, also known as Ozempic, or also known as Wegovy, in treating methamphetamine use disorder. And of course, our hypothesis is, well, it's a wonder drug, it's going to work, and it'll be safe, and it'll reduce methamphetamine use and improve secondary outcomes. Okay. We're aiming to, for this pilot study, we're aiming to recruit 40 participants. These are adults, 18 to 65 years of age, diagnosed with moderate to severe methamphetamine use disorder based on DSM-5 criteria, that they report use of methamphetamine on at least 14 of the past 28 days and have a positive drug screen. Of course, willing to comply with the study procedures, sign a consent form. Sorry for the small type on this that I can't read from where I'm standing. I think of this one, the most important one, and which we debated much, is the level of body mass index, which we would include and not include, right? Semaglutide and the other GLP-1 agonists are really potent weight loss drugs, and so how low can we go with this population? We landed on 22, and this is really consistent with the BMI that was used in the alcohol use disorder trial. And we also have parameters around if we need to stop if somebody is losing too much weight. We don't really expect this because it's a 12-week trial, so we wouldn't really expect somebody to lose massive amounts of weight during this short period, but we have parameterized this. No, it's not me, okay. So study design, again, will be a one-arm, multi-site, open-label study. We're planning this to go on participants under active intervention for 12 weeks. They'll be getting a dose escalation, which is consistent with the packaging, The first 4 weeks, 0.25, the next 4 weeks, 0.5, and then the next 4 weeks, 1 milligram. The maximal dose of semaglutide is 2.4, so there's still, for future studies, much more leeway to figure out how much dose is really necessary to achieve any effect, if there is, of course, any effect. One thing you might notice, with those little ticks, there's different colors. Ones are in blue, the others are in purple. Semaglutide for people for weight loss and diabetes is self-administered. We may or may not have concerns of people using methamphetamine, of what are they going to do with the semaglutide if they have it. It might be hot on the market. So we've decided that for the first 4 weeks, we'll have it in clinic, and then we'll give clinicians and patients the possibility to decide if participants can then take it home and self-administer it. These are the different sites where we're proposing to do this study. 2 here in Sydney, 1 up in Brisbane, 1 in Adelaide, and then 1 in Perth. And this is the list of different co-investigators from the multiple sites and the central team. So thank you very much.
Okay, we're going to move on in the interest of time. The next presenter is Dr. Brendan Clifford. Dr. Clifford is a senior research fellow with the NCRED and a clinical researcher who uses interdisciplinary methods to further health equity and enhance access to evidence-based healthcare, presenting on ketamine-assisted psychotherapy for methamphetamine use disorder pilot study.
Thank you. Yes, as Steve said, I'll be presenting something on ketamine-assisted psychotherapy for methamphetamine use disorder pilot study that's currently underway, so I have no results to show yet, but I'll bring you through a little bit about rationale and what we're doing. I'd like to also acknowledge that I'm on Gadigal land, always was, always will be Aboriginal land. So ketamine is quite an old drug. It was synthesized in 1962 as a PCP derivative. It acts primarily, but not exclusively, by blocking NMDA receptors, I can never say that, in the central nervous system, and it has dissociative and anesthetic properties. So it's been used widely in human and animal medicine since the 1970s. It's an essential medication for the WHO. Aside from being anesthetic, it's being increasingly used for management of complex pain, and there's research established and ongoing into applications in mental health and in substance use disorders. It really got its kind of first kick in its current way from research in the early 2000s into its kind of rapid antidepressant action for people with suicidality. And kind of on the back of that, it ended up with the S-isomer S-ketamine being developed into a spray for nasal administration, approved in the US in 2019 and in Australia in 2021, and listed on the PBS this year. And there's some ongoing research into how that racemic that isomer of ketamine works, whether the ketamine works, and just into the different routes of administration, which I'll come to later, and notably at Black Dog Institute, they've done quite a bit of work there. In the substance use disorder space, there was quite a lot of work just at the start of the century in heroin in Russia by Krupetsky et al. Some more recent work in alcohol use by Celia Morgan and her team in the UK, and some work in the US about cocaine, which is kind of most kind of applicable in this context. So in Dakwar in Colombia, he's done some work that's had some promising results for ketamine, 0.5 milligrams a kilogram for IV, against an active control that's some reduction in cocaine use. The 0.8 milligrams kg IV is actually the alcohol use protocol. There's some cross-tolerance theorized there, and match that with some mindfulness-based relapse prevention, which is really just to give you a basis for what we've proposed for our study. When it comes to how ketamine-assisted psychotherapy might actually work, there's a few different mechanisms that are posited. The first one is enhancing neuroplasticity. So in vivo models, there's some growth of synapses and growth of new neurons. So the neuroplasticity there is one of the mechanisms that helps people recover from whatever disorder we're working with. The functional network disruption, I think John gave a much better description of that. So that's just those networks in the brain that can get particularly associated with fixed patterns of thinking, and disrupting those can help people move on to new ways of thinking. The rapid antidepressant effects that it makes it very useful in depression populations would also have an effect for people with substance use disorders. There's some very early preliminary lab evidence around memory consolidation, so the laying down of memories and disruption of reward memories for substances. There are also some mystical or psychedelic effects associated with some doses of ketamine, and they may also have an effect. But really what we've looked at for our kind of model is looking at this enhancement of psychotherapy, which really would be the neuroplasticity enables the uptake and the antidepressant effects engagement in psychotherapy so that it kind of sticks better. So on the back of all of that, we've devised a protocol for a pilot study of ketamine-assisted psychotherapy with Kat Fletcher and all of our investigators there. Also ably coordinated by Lucy, who was mentioned for the NABU study and is in a parallel session presenting some of her own work. And I'm just going to briefly go over that protocol because it's a very angry red 30-second countdown that I'm looking at. So what we've developed is a 4-week intervention. We've taken an evidence-based CBT protocol, which is the 4-session CBT developed by Amanda Baker et al. And then we've supplemented that with 3 doses of ketamine, using that first CBT as an assessment and kind of preparation session. And then using that kind of neuroplasticity window that's theorized of about 24 to 48 hours, matching our CBT sessions with ketamine in that kind of window, and then following it up. We're not seeking those dissociative psychedelic effects that some models of medication-assisted psychotherapy go with, but they might also occur, so we're kind of working to see how they do. We have got some qualitative interviews. We're taking a range of measures as for pilot, but I won't go through all of them. They are in the protocol paper if you want to look at them. And we are coming to the tail end of recruitment, so hopefully next year I'll come back with some more data. And if anybody is interested, it is on the NCRED website that you can go to, ncred.org.au.
Thanks much. Dr. Clifford, thank you very much. We're going to finish today's session with Dr. Liam Acheson. Dr. Acheson is a early career researcher with the NCRED with a focus on clinical trials of pharmacotherapies for the treatment of substance use disorders. Dr. Acheson is going to be talking about the study protocol for a randomized controlled trial of Lisdex for the treatment of acute methamphetamine withdrawal.
Hey everybody, so a little different to the talks you've already heard of today. This study is not actually interested in treating methamphetamine use disorder or changing long-term treatment patterns, but what we're really interested in is helping people to get through the acute withdrawal syndrome for methamphetamine. Now, when somebody who uses methamphetamine stops or cuts down on their use, they often go through a characteristic withdrawal syndrome, and this can include symptoms like issues with sleep, cognition, appetite, and extreme cravings. Really importantly, we know that these symptoms can be really, really intense. And if we can help to reduce the severity of withdrawal symptoms or cravings, it can lead to better treatment outcomes. And there are still no treatments available for methamphetamine withdrawal. We do, however, know that agonist-like treatment approaches work for other drugs. So, for example, when we use buprenorphine to help manage opioid use disorder. So for this study, again, like with Lima, we're looking to use an agonist to help people get through the withdrawal from methamphetamine. Like Nadine said before, we're interested in Lisdex. I'm not going to go through it in detail. It's a prodrug of dexamphetamine. But part of the reasons why we're really excited about Lisdexamfetamine is also because it is a slow-release medication. We only need to deliver it once a day, and it results in lower peak dopamine concentrations in the brain. We did pilot this treatment intervention looking at a 7-day inpatient treatment where we gave people a 5-day tapering dose of Lisdexamfetamine, where we started people at 250 milligrams of lisdexamfetamine on the first morning that they woke up in our withdrawal management unit, and then we tapered it down by 50 milligrams per day over 5 days. During this study, we found that this kind of dose regimen was safe and feasible for being delivered within an inpatient withdrawal management setting. And we also saw that there was a statistically significant reduction in withdrawal severity over the 7-day period. So we took this information, we got some money from the NHMRC, and now we're ready to go on to a randomized control trial to look at the efficacy of this intervention. So for this study, we're conducting a multi-center, double-blind, randomized control trial looking at the same fixed-dose tapering regimen of oral lisdexamfetamine, but this time versus placebo. This study is a 7-day admission to hospital for methamphetamine withdrawal, and then we are following up with participants up to day 84. We're looking at 5 sites across New South Wales, Victoria, and Western Australia for this study. And I'm not going to go through all the outcomes because there's a bunch, but the primary outcome for this study is a reduction in withdrawal severity. So again, we're not looking for any substance use change. We don't care what somebody's goals are at the end. We just want to help manage the withdrawal severity so that people can then achieve whatever goals they have at the end of their treatment. We're looking to enroll 184 participants across the study and randomizing them 1-to-1 to either the tapering lisdexamfetamine or placebo. We've also got nested First Nations and sleep sub-studies within this RCT protocol. The way the study works is we're going to bring people into hospital. We call that day 0. That's their admission day, and that's when we consent them and we screen them and collect our baseline information. They then get randomized and go on to the rest of their admission. Day 1 is the first morning that you wake up in the unit, and that's when you start your medication. On day 1, participants receive 250 milligrams of lisdexamfetamine, and that tapers down by 50 milligrams per day until day 5. Then on days 6 and 7, participants will receive a placebo washout, and this is so that we can be sure that when the medication stops, whether or not there are any rebound withdrawal or residual effects at the end of the treatment. Finally, we then follow up with our participants once a week for 3 weeks, and then once a month out to 3 months via telephone. And finally, I just wanted to give a really brief progress update because we're actually already recruiting for this study. So we've currently activated 2 sites, one at St Vincent's Hospital in Sydney and the other one up in Newcastle. And to date, we have screened 7 participants and 5 people have received the first dose of their study medication, one of whom has withdrawn. And this is actually old data. As of this week, we've actually had 4 people complete their inpatient period all the way out to the primary endpoint and going on to follow-up. And then finally, I just really wanted to acknowledge the huge number of people who go into running a clinical trial and give a special shout out to our Consumer Advisory Group and our First Nations Advisory Group for making sure that we do the study in the right way. Thank you.
Thanks, Ian. So I have the honor of just saying this is the homeland of methamphetamine studies. This is awesome what is happening here in Australia. Our next event is to invite you to enjoy an afternoon tea. Please enjoy the posters on display during the break. Vote your conscience on which one you like best, and return to here in the main hall at 2:50 p.m. for session 3. Thanks, everyone. Thanks to the presenters.